Well, it's 1:04. I think we may start, and other attendees will join us. So welcome everyone. Thank you for joining us for an ERN-RITA webinar, which is dedicated to newborn screening for severe combined immunodeficiency. So I am Alexandre. I'm a French pediatric rheumatologist, and I'm the medical representative of the medical community of RITA. And it's my great pleasure to be your moderator today.
And welcome everyone. I am Martine Bergeon, the president of IPOPI. I represent the patient community of RITA, and this is my great pleasure to be your co-moderator today. Please do use the chat to let us know where you are joining from. And we want this to be an interactive session, so please do use the question tab, which you can find on the right-hand side of your screen, to ask questions at any time during the presentation and during the Q&A that will follow.
So definitely we want this session to be interactive, so please ask a question and use the Q&A section instead of the chat. So today it's our pleasure to welcome Dr. Fabian Hauck, who is the head of the division of Pediatric Immunology and Rheumatology at the Dr. von Hauner Children's Hospital in Munich, Germany.
And indeed, Alexandre, Germany has started nationwide SCID newborn screening in August 2019. And up to date, more than 2 million newborns have been screened. Fabian Hauck will share with us the lessons learned from their experience. He is going to present the German screening algorithm, confirmatory diagnostics, the SCID-screening-network, as well as the clinical, genetic, and epidemiological patient data. Unmet needs now emerging are going also to be discussed. Welcome, Fabian.
Thanks for the kind introduction, and I'm happy to participate, and I'm looking forward to share these data and insights.
So I think let's go without further delay. We'll start this webinar. So Fabian, the screen is yours.
Okay. So as already mentioned, I would like to present data on 2 years. 2 years of newborn screening in Germany, and I would come to the final question: what have we learned during the last 2 years? And whenever starting with screening for a particular disease, one needs a quite robust definition as a working definition to be sure what you are talking about. So the definition for SCID would be developmental and or functional disorder of T cells, B cells, and or NK cells. And coming from a more phenotypic history in SCID diagnosis, you are all aware of the immune phenotyping, which helps you to classify SCID on a cellular level. And as you can appreciate, always T cells are lacking, with the exception of this one. I will come to that. And so we always have the T- situation, and this comes in various combinations with lacking B cells or NK cells, and sometimes with additional features. But principally, SCID, of course, is a severe T cell dysfunction. So the incidence based on the newborn screening data from the state of California is about 1 in 58,000 newborns in an outbred population. But you can see, of course, that in an inbred population, the incidence goes up. SCID manifests in early infancy with quite a bunch of presentations, but of course, leading ones are recurrent, often opportunistic infections. Viruses, bacteria, fungi, and parasites can be encountered. This leads to failure to thrive because of chronic diarrhea, be it autoimmune or infection triggered. An inflammatory catabolism can be noted in SCID, and not only infections are an issue, but immune and severe immune dysregulation can occur. And when the classical triads of erythrodema, alopecia, and hepatosplenomegaly are encountered, we call this Omen syndrome. So clinical presentation, briefly in greater details, there might be viral infections like rotavirus, norovirus, adenovirus, RSV, metapneumovirus, influenza, parainfluenza, and all the herpes viruses we encountered. Bacterial infections such as otitis, pneumonia, osteomyelitis, meningitis, sepsis can be present, but fungal and parasitic infections as well can be an issue, such as candidiasis, pneumocystis jirovecii pneumonia, cholangitis with Cryptosporidium parvum, and enteritis with Giardia lamblia can be found. And we have live vaccine complications depending on the national schedule, induced by rotavirus, oral polio virus. So now I'm kicked off the presentation. I don't know what's going on. I try to go back. Okay. For some reason, I have no. Okay, maybe now it's working. And BCG can be an issue as well. What is important to mention is that there are all of these infections.
We don't see the correct slides. Excuse me to interrupt.
Because there was some issue. I don't know why. What do you see?
The first slide.
And when I change, is there anything happening?
Not on my side.
Strange, because I see the correct one. I will just.
Yes, maybe share and unshared could be a good option.
Yeah.
What do you see now? Is it back?
Great.
Okay, strange.
Yes,
I don't know what happened. Okay, so as highlighted in red, there are some manifestations which are really typical and classical and should not be found in an infant without a severe immune deficiency. So when you can see, for example, the opportunistic infections and of course the live vaccine complications, you will never see this in an immunocompetent host. So this is really a red flag, as is the Omen syndrome. And of course, graft versus host disease cannot be found in immunocompetent children. So in 2010, there was an important publication by Brown et al. In Blood, because we already knew that the prognosis of SCID is very severe, reaching 100% lethality without treatment. But what these physicians at Great Ormond Street Children's Hospital found was that when they had late diagnosis, at the mean age of 143 days in children that were diagnosed clinically, they had not a very good outcome. So they already had a mortality before stem cell transplantation, which was significant. And the children that made their way towards transplantation again had a quite severe lethality. So in a very experienced leading center, still there was only 40% survival. Again, it happened. It's just interrupting the presentation. Do you see it?
Yes, but not as a slideshow.
Yeah, I don't really know what happens. It just stops. And now you see it again?
Yes,
strange.
perfect.
Okay, I would just have to reactivate it from time to time. Okay, so when Brown et al. Then looked at the siblings of these index patients, knowing that there is a genetic risk in the family, and they did early diagnosis at birth in a non-symptomatic patient, so to say, they had a completely different outcome and they reached 90% of survival. And this was actually a very important finding, because it told us that if we would identify SCID babies being asymptomatic, outcome would tremendously be different. And the question came up, how can we identify asymptomatic newborns and hopefully reach 100% survival? So to screen for a disease, you need diagnostic criteria, of course. So SCID causing genetic condition, of course, would be a very robust criterion. Clinical findings, of course, as I mentioned initially, but this is exactly what we would not like to have anymore. So the diagnosis should be based on immunological findings in a newborn. This is important because the values presented here are different in adults. So in a newborn, SCID can be defined by a T cell count being lower than 300 T cells per microliter, or a T cell proliferation being inferior to 10% as compared to the day control. And of course, a maternal CD3 T cell engraftment would be an indicator of a severe T cell deficiency. In Omenn syndrome, this changes slightly, so T cells can be more abundant than 300 per microliters. Proliferation to antigens can somehow be preserved, but in Omenn syndrome, T cell oligoclonality and loss of T cell naivety that is defined by phenotypic markers has to be present. I will elaborate on this in the next slides because this is a very important concept. And in Omenn syndrome, there's no maternal engraftment, it's autologous. And of course, the clinical phenotype in Omenn syndrome can be present in children, and we have seen this already at birth before screening takes place. So the current IUIS classification has these genetic conditions classified as SCID. This changes from time to time. There were some entities that lost the SCID status, others that have come in to be SCID patient, but for example, RAG2, there's only one patient known, and BCL11B that initially was classified as a SCID is no longer a SCID. So this is somehow volatile, but you can see that we have almost 20 SCID genes at present. So you remember that SCID is a T cell disorder, so it is always very important to look at T cell development. Of course, T cell development takes place in the thymus, and the T cells follow a developmental pathway once they have settled the thymus, and then at the end they will leave the thymus and go into the peripheral blood, being a helper cell or a naive cytotoxic T cell. You can appreciate that during this process, different genetic diseases will create different developmental impairments or blockage. And you can see that in parallel to the cellular phenotypic changes that take place, the generation of the T cell receptor repertoire, which is VDJ combination, takes place. So this is important because this is not only leading to the polyclonal T cell receptor repertoire, this is in addition giving us the biomarker we are screening for. So very briefly, VDJ recombination and drag generation. What is happening? Initially, the T cell receptor loci, they are in a germline configuration, but once D2J rearrangement takes place, the first gene segments are connected together, and then in the next step, a variable region will be connected to this, and then there will be transcription and RNA splicing and finally translation, and this will give you in this case a TCR beta chain. But importantly, the gene segments which are not used, they are cut out, and they will lead to the generation of this episomal ring DNA structures, which we call T cell receptor excision circles, and these are biomarkers that show you that VDJ recombination as a surrogate of T cell development has taken place in a patient. You remember that I was telling you that especially in Omenn syndrome, it is important to understand T cell naivety and the process of homeostatic proliferation. So what is taking place? In the upper part of the panel, you can see healthy, let's say, lymph node niche. And once chemotherapy or radiotherapy has taken place, for example, this niche is empty. But we know that then, as a consequence of an excess of cytokines IL-2, IL-15, IL-7, and recognition of self-peptide MHC complexes, these remaining cells, which are oligoclonal, start to proliferate and will repopulate the niche. And while they do so, while they proliferate homostatically, they will change their phenotype. They are not really antigen experienced. Still, they will upregulate markers which will give them the appearance of being memory-like cells. And this is important because when you have normal thymopoiesis, you will have VDJ recombination, and all the naive cells will leave the thymus having a track. Now, in the setting of a lymphopenic baby, because it's a SCID baby, it might still happen that these cells start to proliferate because of antigenic trigger or autoimmune trigger, or might even be maternal cells that start to proliferate, and at the end will give you normal lymphocyte counts. But no, not all of these cells are naive because they have expanded homostatically. So it is not sufficient to look at the lymphocyte count to rule out a SCID. You have to know whether there are naive cells around, and you can see that this biomarker track is not replicating when there is homostatic proliferation. So this is very important to understand. And this is just to show you that measuring track levels for T cells or crack levels for B cells really gives you nice results in terms of healthy populations, separating from T deficient or B deficient patients or T B minus patients. So it works. And to sum up this first part of my talk, track newborn screening, which would be the correct term, started already 2008 in Wisconsin in the USA. Now is recommended for all federal states in the USA. Germany started almost 3 years ago now, and there's a lot of additional countries, excuse me for not listing them, but there's a lot of things going on that have started or are just about to start track newborn screening. And most importantly, it's easy to integrate it into the standard workflow because it's possible from the Guthrie cut dried blood spots. So the T cell receptor excision circles and sometimes the cracks for the B cells as well, which both result from VDJ recombination and are both non-coding episomes with particular joints where the open DNA is connected and makes the episome, can be analyzed. They do not replicate during T and B cell proliferation, and they can be quantified with real-time quantitative PCR. They are biomarkers for naive T and B cells, but of course, it's just a screening. So these results, when they are positive, must be validated by flow cytometry, and nowadays, I would say must be validated as well by molecular genetics. How is the screening algorithm in Germany? So of course, in the beginning, there will be a dried blood spot, and the vast majority of the children will have a track bigger than the cutoff, and they will just be normal. If this is not the case and the track level is smaller than the cutoff, there are two possibilities. Track might be low or they might be absent. When they are low and the child is more mature than 32 weeks of gestational ages, there will be a second sample test. And again, some of these babies then will have become normal and will not have SCID. But when again, track is smaller than the cutoff, this triggers consequences being a positive screening because there will be an abnormal value confirmed. There's a fast track as well, because when tracks are absent and the child is mature in an immunological sense, there will be an urgent abnormal value. And you can see that abnormal values, they will initially trigger confirmatory testing, which we call level 1 testing in a clinic or a center, while the urgent abnormal values will directly trigger the advanced testing in a center. So there is the standard way, which has 2 levels of testing after the screening is positive, and there is the urgent way. The communication in the German healthcare system is quite let's say, multifaceted. So in the beginning, there will be a sender sending the card to the screening lab, and there will be a result. In the case of being positive, the sender will contact the parents. They will present to the general pediatrician, and there will be a second card and a second result. And if, again, this is positive, then there will be the first level of confirmatory testing, and this might lead to the second level of confirmatory testing. Remember the shortcut of an urgent positive 0 tracks situation where the parents are directly referred to the center. And in this case, the screening lab intervenes as well to be sure that these babies are not lost, and will inform the center, watch out, there's a baby around that should come to you. Of course, there's a lot of feedback necessary to improve and further improve the situation, such as cut-offs, communication. So the hospitals and the centers will communicate with the screening lab, and the screening lab will communicate with the German Society of Newborn Screening, which is not only taking care for SCID, but for all the screening diseases. We have established a network of level 1 clinics. So there are 18 clinics, as you can see, they are marked in blue. And we have a network of centers which can do level 2 and treatment. And there at present are 11, and you can see them marked in orange. This is a moving target because you can upgrade your center, you can be downgraded because there's criteria and there's a process you can apply for being a center or a clinic depending on your center's evolution. So this is regularly checked. Level 1 diagnostics, they can be at a kid clinic. Of course, there will be an interest in medical history and a clinical examination. A complete blood count is necessary, at least IgM and IgG should be done, and immune phenotyping is necessary with absolute counts. And we need to know CD3 positive T cell numbers. We need to know helper T cells and cytotoxic T cells, but please remember the most important testing is this one. T cells, for example, CD4, helper T cells, and there has to be a marker which will really tell you, are these naive or memory-like cells? Remember homeostatic proliferation. And at least at level 1, this would be CD45RA or CD45R0. B cells are interesting and NK cells are interesting as well. When one result is suspicious and there's no prematurity, parents or mothers are asked for to interrupt breastfeeding in case of being CMV positive, and family is referred to a center to have level 2 diagnostics. Level 2 diagnostics are more complicated and sequential, and they are more individualized. So it's not like you do it all, but you do a part and then you think and you reconsider, and then you will build up your diagnostics, because this is already the beginning of getting the transplantation started. So there's a lot of additional things, such as a second marker, for example, CCR7, to really discriminate naive and memory T cells. Recent thymic emigrants should be looked at. Alpha beta and gamma delta T cells should be distinguished. In the suspicion of oligoclonality, a TCR-V beta repertoire analysis has to be done. Functional testing is mandatory, such as T cell proliferation. There might be the need to check for ADA and PNP enzyme activity and metabolites, because at least in this case, there's enzyme replacement directly or indirectly via blood transfusions. Radiosensitivity is a big issue because this really makes a difference in how you condition your baby, and maternal engraftment has to be excluded. When results are confirmatory of being a SCID, there should be a molecular genetics workup. We have established guidelines for how to treat these children as well. So of course, SCID, leaky SCID or OMAN, they will need a stem cell transplantation or gene therapy at a kid center. In case of having syndromal T lymphopenia, there will be a follow-up at kid center. In the case of idiopathic T lymphopenia, so T lymphopenia is around, but we don't know why, and the child is doing well, again, there will be a follow-up at the center. Prematurity will lead to a control. Secondary lymphopenia will be treated following the cause of secondary lymphopenia. It is very important that all these things go hand in hand with registration. So we have the SCID registry in Germany, we have the SCID registry for Europe, and we have the registry of the German Society for Neonatal Screening. And all this work, unfortunately, is necessary to optimize the process, and maybe not too far away in the future, these registries will talk to each other and it make easier to get the data into all of them. But we will see. Just to give you an idea that it can be very laborious and that you're not the only center or country that is fighting to have SCID screening, I will show you the process or I will show you what it took in Germany. So in already 2012, patient organizations and medical societies approached the National Association of Health Insurance Funds for support. 1 year later, the German Pediatric Working Party published a first screening algorithm, and we initially suggested track screening and crack pilot screening. 1 year later, the health insurance funds saw potential benefit for track screening and submitted a petition to the Federal Joint Committee for formal evaluation. 1 year later, systemic evaluation, which is literature review, expert and patient organization hearings, and so on, was carried out and finally gave the answer that there's a potential benefit of track screening, but that there's insufficient data to evaluate crack. Almost 2 years later, then the GBA published a project draft to include SCID as a new target disease to the German newborn screening. And again, this was sent out for final statements, hearings to all German medical societies. And in November 2018, track screening was added to the routine NBS, and this was published, becoming a law, implicating that 6 months later, this must be reality. So now again, especially the RP, the German Pediatric Working Party, started to establish the structures I already showed you, and we identified referral centers and set up level 1 and level 2 diagnostics and all these communications in between the players. And with that, I come to my summary. So severe combined immunodeficiency is a developmental and or functional disorder of T cells, B and or NK cells. It leads to severe immunodeficiency and immune deregulation, has 100% lethality without treatment, but can be cured, especially with allo-HSCT. I don't show you the data on our cure because this will be part of the manuscript, but I can tell you that with a short follow-up, we have almost 100% of cure. So the outcome of the stem cell transplantation depends on early diagnosis, of course. Track are invariant and non-coding episomal biomarkers. Germany started newborn screening 2019. SCID must be confirmed by flow cytometry and genetics. Diagnosis, at least in Germany, is done at hospitals, level 1, and centers, level 2. Every SCID patient needs individualized immunology and genetics. Every screen patient needs high quality documentation to further improve the process. SCID screening has dramatically increased the diagnostic yield, and treatment data is going to be submitted soon. Now, the final slide, or almost the final slide, and this is what we should discuss, I think. What have we learned? We have learned that SCID screening works very well. That's good. We have learned that SCID, leaky SCID Omen syndrome, occurs in 1 in 50,000. And this means that we missed half of the cases before, and this might be because of homeostatic proliferation, where the babies are very sick, but they have normal lymphocyte counts. So be aware of that. We can treat SCIDs very well. Data will be submitted, and we have EBMT guidelines, for example, which have been updated recently. So we know what to do in these cases. But related syndromes occur even more frequently with 141,000 patients. We missed almost all of them because there was some kind of misconception. Okay, this baby has a neurological disease, there might be recurrent respiration and so on and so on. This might lead to pneumonia. And neurologists or developmental disorder specialists just were not thinking in terms of immunodeficiency. And this is not criticism, because we as immunologists, we do not think in ways of global developmental disorders, because we are not used to and we are not trained to. But as a consequence of this neglect, we cannot yet treat them very well, because we don't have thymus transplantation. This is not yet available in Germany. So at present, we send them to London, but you're all aware of the particular situation and the increasing number of patients, and this will become even more problematic when additional countries start screening, because when all Europe does SCID screening, it's not possible to send all these children to London. It is important to have more awareness in neighboring disciplines, which is not yet established. So we need to reach out to neuropediatricians and educate them, think SCID. We at present have structural problems as well, because quite frequently these very complex children, because they might have, of course, T-cell deficiency, they might have developmental delay, they might have orthopedic problems, and so on and so on. They are treated in a multidisciplinary setting in what we call sozialpädiatrische Zentren. But in this setting, there's no immunologist. And the entire setting is not adapted to someone who needs to be separated or isolated. So we have homework to do, I think. And to end my presentation, severe T-cell lymphopenia overall can be found in 1 in 21,000 children. I would like to thank you for your attention, and I would like to mention the people participating in the SCID newborn screening group, which is Michael Albert, Sujal Ghosh, Manfred Hönig, Katharina Schütz, Ansgar Schulz, and Carsten Speckmann, who will give a talk on SCID screening with more recent data at the upcoming ESID meeting. So thank you very much for your attention, and I'm happy to discuss with you.
Okay, so I can applause in front of my screen. Thank you very much, Fabian, for this fascinating talk. I think we have already questions in the Q&A section. So I've seen that we have people connected from Egypt, Greece, so welcome to them. And we can start with the first question from Maria Suman. So what is your process regarding CMV and breastfeeding? Do you pause after the first abnormal finding? Or what do you do for preterm babies? And do you pasteurize breast milk in all until the SCID diagnosis is excluded?
Yeah, so this is a very important question, and it's a very clear question, but the answer is not that clear, because every center has different policies. Even in Germany, it is very heterogeneous how the milk is prepared for preterm babies. So this is very variable. There are some centers which will pasteurize milk. There are other centers which will freeze it down and heat it up again. There are people who will just switch to non-breast milk. So we don't have a final recommendation on this. And in addition, for the family and the mother, it's very traumatizing to tell them, do not breastfeed your baby, because this is one of the most deeply inherited needs for a mother, to feed the baby. So this is very a hot topic, and this is why we try to be fast, because we know that during the first days, CMV transmission is not the most problematic thing, because once the mammalian gland starts to produce milk, CMV will become activated down the road. So we have a little time window to really be sure whether this is SCID or not. So the recommendation is be fast, because this will avoid a lot of problems.
Mm-hmm. Thank you. We have many questions, in fact, and the next one comes from Kimberly Gilmore. What percent of urgent referrals, absence of tracks, had normal immunology, and what percentage of abnormal were normal?
So I am aware of 2 children that had 0 tracks and were totally normal. And the reason for this is not quite clear, but it looks like that sometimes in this signal joining sequence, there might be polymorphisms around, which are very rare, which interfere with the binding of the primers available in commercial kits. But this is ultra rare. And the second part of the question was, how many patients did we miss?
Yeah,
I think Fabian, in the question, I think Fabian, there is how much. So you need to screen the patient to have a great sensitivity, and then you confirm the diagnosis. And how many patients are excluded from the definitive diagnosis, but that are screened a bit more? And what's the proportion? Is it
okay, the
99% that will be
false positive?
Yeah, we don't have the definite numbers yet, because we are only this is still work in progress, but the sensitivity is quite good, so this is not a big issue actually. So we don't have too much false positives. It's not a lot, because we have low thresholds and we don't have cracks, because when you have cracks, this might totally change, but we voluntarily opted for that way because it's the first immunological disease which has become part of the national screening program, and we would like to have more diseases on board in the future. But before this, we need to show that this is doing good and not harming people, to have a general acceptance of being immunodeficiencies part as screening. So we have quite low thresholds and we have no cracks, and by that way we don't have a lot of false positives. We might miss some children which from a medical point of view would benefit, but at present we're not screening for syndromic disorders, but we're screening for SCID.
Okay. So another question from Maria Suman. So what are your prophylactic measures? So I guess in between at the time you made diagnosis, so that's a sort of same field of question.
Mm-hmm. There is variability again, because every center can do his own things. We are working on a guideline on that, but in principle, of course, it is immunoglobulin replacement therapy. It is cotrimoxazole to prevent pneumocystis jirovecii, and it is not giving live vaccines to the children. This is, I would say, standard. It becomes a little bit more heterogeneous in terms of antifungal prophylaxis. So there are some centers which will give fluconazole. There are other centers which will give only nystatin or nothing. And when it comes to monoclonals, the heterogeneity is present again, because there are centers which will give palivizumab in addition to immunoglobulins. Some people tend to give monoclonals against coronavirus and so on. So the mainstay, I can say, is immunoglobulins, cotrimoxazole, do not live vaccine. This is very clear, and of course isolation. So avoid contact to infectious diseases, and whether this has to be in a hospital or at home really depends on the socioeconomic situation. So if there are 20 children around in the family, it's maybe not the ideal place for a SCID baby. If it's the first baby living in a mountain castle, then you can leave the baby at home. So it depends.
Mm-hmm.
We have another question, a tricky one from Maria Suman. Are there efforts to start thymic transplantation outside London and the US?
Can you repeat the question, because there was some technical
Sorry.
issue?
Are there efforts to start thymic transplantation outside London and the US? Because you mentioned that it was not available in Germany.
Yeah. I'm not aware of efforts at present. The only effort I'm aware of is me telling you that there's a problem. But I think this will be a discussion quite soon in the community. Yeah.
So I think the next question from Nicholas Brodsky is
and also
the one.
there is an alternative.
Oops.
Sure.
Sorry, Martin. So I think the next question comes from Nicholas Brodsky, but this is already answered. So it was about this number of patients that were screened positive and at the end excluded for the definitive diagnosis. And you mentioned it's not so many, so there is not a big issue and stressful situation where the parents are scared by the SCID diagnosis that will at the end will be excluded. So it's not.
I mean,
so
maybe I would like to add that, of course, in neonatology, in the premature babies, this is an issue. So the majority of the children that have a positive screening but are not SCID are premature, and or very severe children which have infections, inflammation, organ failures, and this sometimes can be tricky. But this is secondary lymphopenia, and in healthy children which are at term, we don't see this.
Mm-hmm. So
I have two questions. Oh, sorry. Go ahead, Alex.
Please, Martin, please.
I have two questions for you. The first one is, how long should be the time after your experience between the diagnosis and the treatment itself? Because in some countries there is a limit.
We try to have them transplanted starting from month 3 of life. So this is our goal. We prepare these children for transplant when they are 3 months of age, because we want to grow them a little bit, which makes it technically easier. We want to have the organs more mature, the liver and the kidneys, so they tolerate chemotherapy better. But we don't want to wait too long. So there's no data really showing this, but the approach we have in Germany, which is somehow agreed in between the centers, is around 3 months.
Okay, thank you. And the second one would be, how do you handle parents who have their asymptomatic child undergoing a very severe treatment? How do you deal with that? Because it's not always easy.
Yeah, right. When you have a family that already has lost a baby because of SCID, they know the burden of disease. So they really know what the disease can do, and they are happy to only have the burden of treatment. But in a family which never ever had contact with SCID or immunodeficiency or even disease, and now you tell them you have to isolate, you cannot breastfeed, you have to do this and that, and you have to go for a transplant, where they only see burden of treatment, this is a problem. And this is not an issue only for SCID screening. You can see this with the vaccinations, for example. So this is something which is time consuming, and you have to talk to the parents, and you have to explain them, and you have to somehow try to convince them. And at present, I'm not aware of a family that at the end refused. But sometimes you have really to struggle a little bit. Yeah.
Thank you. Thank you very much.
Fabian, it's my turn to have 1 or 2 questions. So the first one, so I'm a pediatric rheumatologist, and we have some rare situation where there is an early onset autoimmunity that will not be catched by this strategy. So do you think there is an interest in the future to consider a neonatal screening for monogenic autoimmune disease or autoinflammatory disease?
Yeah, we have 482 monogenic diseases in the current classification, which lead to some kind of immune deficiency or immune dysregulation. We cannot treat all of them, and not all of them will start in infancy and are very severe, so fulfilling the classical criteria for a screening. But from a medical point of view, I think, and this has been not only my personal opinion for several years right now, that it might be a good idea in the future to have some kind of genome sequencing with a virtual panel to really figure out like these diseases like C1q deficiency, or you name it, C4 deficiency or TLR7 gain of function, things like this for you as a rheumatologist, which really can cause harm to the children, but which are targetable. So in the future, I think we will have some kind of genome sequencing with a virtual panel. We will only look at genes which are interesting for us, and the rest will be discarded.
Mm-hmm. Thank you, Fabian. So another and last question regarding the long road that you mentioned to set up this neonatal screening. How did you advise other countries that are attending this meeting? And have you involved patient organization or association in this long road to make them partners of this history?
Yeah, so there were several rounds of hearings where not only medical communities, but as well patient organizations were asked to give statements and to give their expertise. And I think this is very important because in the end, having a screening disease is touching upon the entire population. So you need a broad consent, and you need to include all the groups. And this is not only doctors and nurses and patients. This is health insurance companies, and this is lawyers, and this is people coming from the religious field, because there's always an ethical debate as well. Yeah, but one thing which is really important to convince policymakers is to show success stories from other countries. Saying like, look, the US is doing it and it's working, and we have successful programs already that have come to an end in France, and Germany now is doing it and it looks good. So this is why we are pushing the publication, because I think this might help to convince policymakers, because when your country will not have 84 million people, but maybe 10 million people, to have the numbers to really prove that it's working takes too long. So you should somehow use the data that's already around now.
Absolutely. I think also that we can mention that there are a consortium working on that, especially to push information and experience sharing with Screen4Rare, for example. And also, if you want to know every country in the world who is doing newborn screening for SCIDs, you can have a look at the PID Life Index, and you can find every country doing that already, or having pilots.
Yeah, maybe you could post these email addresses in parallel with the talk on the RITA website.
Yeah, excellent. So thank you. I think that you have now reached the end of this webinar, and on behalf of ERN-RITA, I would like to say a warm thank you to you, Dr. Fabian Hauck, for this excellent session and for the discussion that followed.
And thanks again to all the attendees of this ERN-RITA webinar. So before we go, I would like just to invite you to attend the next ERN-RITA webinar that we have now named the Lunch with Rita webinar, that will be every first Tuesday the month, except the next first Tuesday of the month, because it's bank holidays. So see you the 8th of November, if I'm correct, yes, and it will be on tattoo and immunosuppressive drugs. So that's very interesting. We jump from neonate to adolescent and adults situation, very practical, how to manage this sort of situation that will interest the whole community. So come there, and thank you again for joining. You will have a questionnaire at the end of this webinar, so please, at the end, answer this specific survey that will help us to improve this session. So thank you for joining, and see you there next month.
Thank you so much. Bye-bye.